Thank you very much. First of all, thank you to Shona and Sudeep. It's always utmost pleasure to be here. This is, to my mind, the best conference. I learn more in a day than I would learn anywhere in a year. Thank you. Great panel, a lot to discuss. I don't know how I'll finish in 45 minutes, but I'll carry on. And thank you, Dr. Hope, for that lovely lecture, which I think covered most of it. But really, I think this year was about TDXT, and we kept hearing about it. So I've literally divided my whole discussion into two parts, TDXT and everything else. But first, what does HER2 mean? Chetan, can I start with you? What does HER2 low and HER2 3 plus mean? I mean, it's very confusing.
HER2 overexpressed is
IHC 3 plus
IHC 3 plus. If
yeah.
you have a HER2 2 plus and which is positive by fish, then that still becomes
High.
over. If it's HER2 negative by fish, then it becomes HER2 low. HER2 1 plus will also be considered HER2 low. HER2 0 is truly 0.
Okay, so he's somewhat clear on this. Atul, I know he has a flight to catch, he may leave early, but this
got delayed by an hour. So
okay, it's further delayed. So all of us going to Delhi, we don't know we are reaching or not, but so this really confused the hell out of me because this is a very pertinent paper and Priya read this out, which essentially is talking about a different way of HER2. This was done in HER2 1 plus as well, and essentially they're saying if you've got a HER2 amplification, then you actually are separating your curves very nicely. So does that mean, or could it mean rather, that the HER2 1 plus 2 plus were really responding and some HER2 3 plus because TDXT was maybe using fish, although this is not for TDXT, but using the HER2 amplification rather than a standard IHC expression?
this is intriguing, I think, looking at those 1 plus. Now, one it says is that it's a continuum of expression, right? It's going from ultra low to positive to probably ultra high as well.
Yeah.
Right. That's what it
ultra
says.
high as well.
And it's a little difficult to understand because one, we are looking at the protein expression at the IHC, right? And the antibody has to bind to the IHC. So the efficacy should ideally be as per the protein expression rather than the mRNA or DNA. All DNA and
Fair
RNA
point.
would not get to
Very fair
protein,
point. Very
right?
fair point.
All those expression things are happening in between.
Yeah, fair point. Dr. Hope, can I ask you this? Did any of these trials, in fact, look at the HER2 amplification the way it has looked at this study? I'll come to you in a second. Yeah.
Yeah, I mean, no, that's good. The trials actually had central confirmation of HER2, and so you had to be 3 plus or 2 plus with gene amplification. So
Yeah, but what I'm trying to say is, if we were to forget the HER2 IHC completely, and Atul had a point that maybe we should not, but if we were to ignore that, did the trials just put HER2 amplification as a continuum and see whether there was an effect on that over and above 1 plus 2
Well,
plus
so
3 plus?
we've seen this already with trastuzumab.
Yeah.
So if you look at the benefit of trastuzumab, and a number of investigators have published this, that when the ratios are lower and the copy number is lower, the benefit is less.
Yeah.
You still see benefit, but I think it's a little bit unclear when you're at the very low twos, how much benefit you're getting. So my take on this was it's actually very similar to what we'd already seen in treatments for HER2 positive disease, and notably trastuzumab. And it looks exactly like what the DAISY trial has also showed, that if you're HER2 positive, you have a really good PFS, and it goes down as you have less HER2 expression and less gene copy number.
Yeah, great. Mosmi?
Yeah. So this is about the HER2 protein expression. So I have done a study also comparing the HER2 proteomics to mRNA expression as well as to fish. So one thing is, when you look at the protein expression, that is the IHC. If you take a fresh frozen section, what may appear to be negative on your IHC on a paraffin block may be positive, 1 plus positive if you just take a fresh tissue. Okay,
I'm
so
going to come back to you on that. I'm actually covering that aspect in my talk today. I will come back to you.
okay. So that is the thing. And this was a study of some more than 100 cases where the RNA for the mRNA for the higher cases did correlate, and there was one intermediate area also, which was like 2 plus in the RNA. And again, this is RNA from the paraffin block. So this is not from the fresh tissue. So there are a lot of
Changes that are happening,
changes
that's
that are
dynamic.
happening. So yes, the IHC and the fish did correlate very well. So that's why it has been there. But I'm really surprised that why we have come to this now, that low amplified versus high amplified. So why are we talking? This has been there since many.
No, I think we're talking more in terms of the fact that we are trying to find the right patient for TDXD in an Indian strata where this expensive drug. So you want to find the right patient for the right treatment. Of course, toxicity matters, but in that respect, everything I can find to have the right patient be treated correctly.
Yeah, because in that HER2 study also, they have not taken the HER2 zero.
No, they have not.
They have not taken that, and 1, 2 are considered. And I'm telling you that if you do on a fresh tissue, so you don't
Okay,
know.
I'll pause you there, Dr. Shyam Agrawal, then we'll move forward.
So taking the same point ahead, when you look at HER2 low, there's so much of discrepancy amongst the pathologists to look at, HER2
Absolutely.
1. So is this the time to look at the proteomics and determine the efficacy of TDX2 vis-a-vis the expression
Rather than
determined by proteomics?
just looking at HER2, 2 plus, 1 plus. Yes, ma'am.
Actually, Chip Petricoin just published some data looking at proteomics, and I think it's really a fascinating additional indicator of response and biology. So a really important area for investigation. I don't know how much it's really going to be for prime time, though. It's still so complicated, and there are too many proteins being evaluated. But he's looked at phosphoproteins, really fascinating data just recently published. But the question about 0 and 1 plus is interesting because, David Rim's data published suggested that, there was like a 50-50, calling 0 and 1 plus. But if you look at the central versus local concordance in DB04, it was 88%.
Yeah,
So
but
almost
Dr.
all
Hope, to
were
be fair, we are
concordant.
talking about the center and the second opinion kind of being very high quality centers. We are talking
No,
about.
a lot of centers did DB04 all over the world, so
Okay.
these weren't all, big, huge academic
I'm going to
centers.
move
So I think the concordance was good, and then other investigators looked at Concordance Central and presented them at that same San Antonio session a year ago. And again, in some settings, the concordance was very high.
Okay, I'll move forward. Sorry, yes, Dr. Da.
From practice point of view, it will be HER2 0 or HER2, any HER2. And as the drugs go on being more effective, any amount of HER2, I think so it should work. So in practice now it should be only 2.
Okay, so I think we'll move forward from here. I buy your point, but really, what even Dr. Hope, in fact, answer to Dr. Sudeep was, there is a lack of clarity on exactly where and how this ADC sits. And I'm sure it's a continuum of efficacy as well. I don't think every patient in HER2 3 plus is responding equally. So there's more to know here. But TDXD had really, it's changing an outcome. Dr. Gulia, I'll take your view on this. So this was DB02, phase 3 trial, very well run. TPC was the standard of arm. Just a quick one, 20% had brain mets. Almost everybody received TDM1 before, so heavily pretreated. And this was predominantly 2 to 3 lines of therapy in almost everybody, and yet it showed some great benefit both in OS and that in all the papers. So how do you see this? Is this new standard of care, and any concerns about TDXD in this population?
So indeed, this is a new standard of care, at least in second line and third line. Only major concern is the interstitial lung disease that is seen even in trial level. It is seen in 15% of the cases.
Yeah.
So we need to choose our patient
We'll do
wisely, and we need to reduce the dose and withhold the dose as and when it is. We have to preemptively suspect that the patient might be having
So
ILD.
we'll in fact discuss toxicity at length. I have a whole set of presentation on that. But any concern about the data? Any concern about who to include? Any concerns about that? Dr. Gulia first.
So this included HER2 3+.
Yeah. Yeah. Okay.
So if we talk about
You're generally more
0 to
confident of 3+.
3+, yeah, but the data is equally effective for
For two.
1+ and 2+.
Okay. Dr. Dava.
Those who have extensive lung metastasis or slightly breathless, would you use them, ma'am?
We'll come to toxicity in 5 minutes. I want to discuss toxicity separately, but any concern about HER2 3+, multiple lines treatment. So it's very clear, I think, from the panel at least, that for patients who have progressed on 2 to 3 lines of therapy, we're generally comfortable. Data is good, and then no other than toxicity. But this was, Atul, I'll come back to you on this. So this was DB03, which compared to TDM1, can I ask you first, do you believe in TDM1 was a very effective drug for most of your patients?
It's a modest activity drug, but
Okay.
it's the right comparator, right?
Okay.
We cannot ask for a better comparator, and
Because it's the standard of care at that
it
point.
is the standard of care. And I mean, there are few trials where we don't have to discuss about the efficacy. The curves speak for themselves. These are kind of the trials, like the curves. The difference is 21 months. How many times do you see that even in a decade?
Yeah. Okay, so I have a question to you and then to Rohit also. So if you notice the number of patients who had only 1 or 2 line of therapy, because obviously this was TDM1, was a predominant population here, as compared where we saw that predominant was 2 or 3 lines of therapy, and yet actually the curves, separation and the PFS are very similar. What's your view on that? First yours and then, okay, Rohit, why don't you take that?
So I think no, this comes into play with how do we sequence drugs now? Where does TDM1 stand when TDXT
Exactly,
becomes the next
exactly.
standard of care? So toxicity is one thing that would guide. Probably any patient who has some symptomatic ILD, they were not taken into these into the TDXT studies. Also, we need to look at the mechanism of resistance now. Now, where do we sequence a lapatinib sort of a thing in between two ADCs?
I'm asking more from a clinical perspective. In the outpatient, as the patient walks into your room, are you thinking you will put this up as second line or as third line? I think that's the key question.
I would go for second line. Use
You
the
go for
most
second
effective
line.
drug quicker.
Okay, Atul, back to you.
Agree with that. The most, if the patient can take, then second line.
Okay. So Dr. Saurabh? No, okay. Manu Prasad? No, they're not there. Okay. Right. So,
Pertuzumab was used.
sorry, say that again?
If the pertuzumab was used, were the results similar between TDX and this?
Yeah, in this group. So,
When trastuzumab and pertuzumab both were used,
yeah, there we are.
then I think so trastuzumab deruxtecan was a much better option.
No, that's not true actually. Everything is on the left. But yes,
There is some data for that.
Dr. Hope, your view on that?
That TDXT was better regardless of the subgroup. And so number of lines of therapy, brain mets, hormone receptor status, and previous
Use of
pertuzumab.
pertuzumab also.
And previous pertuzumab. Which was interesting because it may be, there was a little bit of data that suggested that post-pertuzumab, TDM1 still worked, but didn't work
Yeah.
quite as well.
Yeah.
And so that's, I think, where we're, maybe there's even a greater benefit, but it didn't matter here. TDXT didn't seem to care whether you had pertuzumab.
Okay. Dr. Agrawal here? No. Okay. So this was the other toxicity profile. As I said, we'll come back to toxicity. So what line of therapy, Chetan?
Looking at the toxicity profile, I would prefer to use it in the second line. As my patient progresses, probably patient may not be in a shape to receive a toxic drug.
Okay, now if I
And the
was...
efficacy is good.
Now, if
So
I was to bring cost in perspective, because it is, we are seeing efficacy on both sides now, and TDM1 is clearly cheaper, especially for us in India. If I put cost in perspective, would you still hold the same view?
No.
No.
Right now, it's just not feasible for probably 99% of our
Yeah,
patients.
yeah.
So that is, if cost equation comes into picture, then it's the obvious choice is TDM1.
Okay. Okay, and Dr. Hope, this is a question for you. What after TDXD failure? And we do not have the trial drugs which you showed on your slide. We really don't have them.
No, and I think that then we would, you have oral TKIs, right? You have lapatinib,
We have lapatinib. We
So-
have, okay.
but not tucatinib, right?
No, we don't have
Yeah,
tucatinib.
and and pyratinib is really cheap in China, but I don't think you have it here. So and that's also a very effective next generation oral TKI. But I think, a lapatinib combination, trastuzumab combined with chemotherapy, and of course, if you gave TDXD, I would give TDM1 maybe after one other agent, in
Okay.
sequence.
Yeah,
I think, with cost as a consideration, it's interesting that DB02 showed improved survival so that you could give TDM1 and then give TDXD for a shorter time period, it would be less expensive. So.
Okay. Sudeep?
So quick question, what percentage of patients in these trials actually went on to receive DDXD after disease progression?
In in DB03, it's in my slide, it was about 17% who got TDM1 first, who then got
TDXD.
TDXD.
So if a greater proportion of patients were to receive DDXD after disease progression, would that abrogate because the overall survival is not as markedly
As the PFS, yeah.
different as the PFS, and perhaps you can get away with a smaller duration of use of TDXD
By giving it in the third
by
line setting.
giving
Third
it in the
line.
third line while
That's what I was
achieving,
just saying, yeah.
while preserving most of the overall survival benefit.
And that's what I was saying, that in India context, considering that price is of some constraint, that may be a strategy because we still saw
If
efficacy.
that 17% had been 60%, then one would like to look at the survival curves.
No, absolutely. And I think it's a big issue, I think that ethically, we've been talking about this more recently, that, the FDA wants these endpoints which require that you can't cross patients over, which means that, people participate in trials and they have no access to the drugs, which you already know are better, or at least good. And so it's a frustrating thing that we don't have a solution for right at the moment. But I agree. I think that, it's interesting that in the TDXD arm, more patients got TDM1 after TDXD by a lot compared to TDXD after TDM1. But I think in a resource, limited setting, giving TDXD after TDM1 is one potential option.
Yeah, sir.
Yeah. So Nitish, two practical questions. Two categories of patients. One who have a COPD, who are not on steroids. So do you start with the lower dose, number one?
So toxicity will come in a minute. I
And
want
the
to
second is the renal insufficiency patients. Do you begin with the lower dose because of the high incidence of ILD?
So I'll ask those questions in toxicity. This was the pooled analysis of TDXD in brain mets, and I think this is a very, very important, and I think you covered that as well. Sarah Hurwitz presented this, and they essentially divided that into TDXD patient with brain mets pool versus the comparator, and we saw clearly a great efficacy in both actually untreated as well as treated, but obviously the untreated was more. So TDXD, HER2 3+ effect on brain mets, are you comfortable? Is the data good enough? And does it mean, because it was the untreated which also benefited, again back to maybe Dr. Seema Gulia, you can take this. What's your view on brain mets and TDXD? And we will discuss more brain mets with other trials in a minute.
So these are the patients who had active brain metastasis.
Yes.
Still shows response rate of 45%, which is remarkably high. So I believe that TDXD definitely works in brain metastasis. If patient can afford it, then I would prefer TDXD. But if cost is an issue, then TDM1
Yeah.
also has
Some
significant
Okay.
efficacy in brain metastasis.
Rohit, let me ask you something that there was some articles suggesting that lung mets, for example, is a predictor of brain mets in HER2 positive clone and so on and on. So wouldn't those patients you'd be really pressed to use TDXD in earliest possible line?
So you're trying to ask that if patient has both lung as well as brain metastasis, then using TDXD.
No, if you don't have brain mets, I'm saying if you don't have brain mets, I'm saying there are any predictors in your mind which would push you. I think Dr. Hope also answer that as well. Why didn't you take that, Dr. Hope?
I don't think we have any defined risk factors other than having HER2 positive disease.
Yeah,
you
of
know?
course, that
And
itself
the
is.
longer you have disease, the more likely you are to have a brain met. And, you know, because we know that some patients present with brain-only disease, you know, brain and bone,
Yeah,
or, you know,
yeah,
any of
yeah.
these things. So, you know, I have seen really nice efficacy of TDXT in patients who have, you know, progressing brain mets where we've exhausted radiation, or, you know, you've radiated some of them. They get, you know, a patient with radiation necrosis. We don't want to radiate again. And with incredible control, very
Yeah,
durable.
yeah.
I have not seen the same degree of control in HER2 low disease. You know, so it's interesting question, you know, whether or not it's going to work quite as well. The PFS is also not quite as good. So.
That's a very important point you make, Sudeep.
Very quickly, anecdotally, one of my patients with HER2 low breast cancer with meningeal, with widespread meningeal involvement responded beautifully to
So
treatment.
again, Sudeep,
I've seen that also. A really beautiful response, lasted 3 months or something, didn't last very long, but beautiful response to leptomeningeal disease. But, you know, everybody I give TDXT with HER2 positive disease responds. Not the same with HER2 low.
so I will actually bring this up in a minute, but to your point, HER2 is also a dynamic marker, you know, so we don't really know where it is in fact escalating with progression or not, and I think that may mean the change. But I agree that it's extremely important drug because all these patients end up with brain metastasis, and the quality of life, quantity of life, both are affected, and often when multiple lines of therapies have failed. So to have a therapy for these drugs is I think very critical, and therefore it does mean to my mind that at least for patients with brain mets, I'm very keen on bringing it earlier in line rather than later in line because the control is poor. Okay, so the hot topic, HER2 low. As I said, I'm not very clear. HER2 amplification level, does it have a predicted low regardless of IC? And which biopsy? So these are the two issues that I'm facing with HER2 low. Which is the fish which we discussed, and does that mean? And this has, that Hope said, already been looked at before, that HER2 ratios to predict pathological complete response following neoadjuvant doublet therapy. And they, if you can see that on the left, they are clearly showing how those ratios at a higher level are predicting pathological CR, and they are also suggesting that HER2 amplification actually is a continuum. Mosmi, I did tell you that I'll ask you to come back and speak about this briefly. But the other point is, please, but the other point is also, and which is very interesting, which is to your point, Sudeep, that HER2 is a dynamic marker, and this is in fact triple negative breast cancer patients who had repeated biopsies, going even up to 12 biopsies in one, not 12 biopsies, 12 patients had up to 9 biopsies. And what they saw that as they increased the biopsy, in fact, the HER2 low at least went up to 100%. So their conclusion was HER2 status is a dynamic in patients with TNBC, and they support the idea that HER2 low is a spectrum, not an entity, and further basically are suggesting that HER2 should be rebiopsied at least a few times in triple negative breast cancer. So your point to both these points first, and then maybe I'll take the panel's view on that also.
So first in the trial, if you have a primary biopsy that was HER2 1 plus or 2 plus, and you have not given NHER2, and you have a secondary one where you have HER2 0, you can offer that patient
So
thing
this
based
is
on the primary biopsy.
this is to the point, and Dr. Hope, correct me, HER2 1 or 2 at any point in the patient biopsy was
Yes.
the inclusion criteria, not the latest biopsy. Yeah.
Yes, so that is there. And
Inclusion was supposed to be the latest biopsy, but it
Was
turned
it?
out,
Okay.
yeah, but it turned out, you know, people were using whatever would get the patient into the trial, right? So,
But they were
some of the
using archival
biopsies-
biopsy to be
some of the
retested.
biopsies were 7 years before. You know,
Wow.
so.
Okay.
so, and another thing, when we do fish HER2 counting in fish, what we are seeing is contiguous 20 cells. We are counting them, and you know it is a observer's this thing, like you which contiguous cells you count. And what I have noticed in my reporting is that there were cases which I had reported as low or non-amplified, which were like borderline, and I saw them coming back as HER2 amplified. So after that, this
The
was
same
a person.
patient.
This is patients. I'm telling you my own experience. Though this is not in the guidelines, you should do the contiguous counting and you choose which area.
Yeah,
And
yeah.
it's a dark thing there in the fish, and it's difficult to choose. So these are practical things. So, and I have found that, and since that, then it's been my personal bias. I slightly over-report if it is a borderline, like low, non-amplified. I think it's better. And this thing has come after that, like so.
Okay. Okay. So I think what I'm hearing is these are difficult areas. We will vote on this as well. This was Destiny Best of 4. Atul, I'll take your view on both these points which are raised, as well as DBO4. The fact that if you look at the entire cohort, you see they were very, there was a clear difference in treatment there. So your conclusion on HER2 low, are you convinced data as well as what Mosmi was saying about the interpretation, as well as about the fact that the fish, as well as about the fact that it increases, it's a dynamic marker.
So HER2 low is okay because we need 1 plus is a problematic area. 2 plus fish negative are still okay. I think where the most of the problem lies is between 1 plus
and 0
is the dark area. And then further, I think getting that to between 0 and 1 plus, will have to kind of recategorize those. Especially for metastatic setting, it would still be okay, but when these settings start coming up in the neoadjuvant and adjuvant
be bigger
residual
problem.
space, that is going to be the real challenging space. When you
Right.
start off with a TNBC with
And then you
AC
see
tax
1 plus,
carbo
okay.
pembro and you see a HER2 low 2 plus.
And while in practice
What
we
do you
don't,
do?
while in practice we're not checking it again after
We
surgery.
are not, but this is what I contemplate that would
We will have
happen
to do,
eventually.
we'll have to.
Like if you start a TNBC on HC tax carbo pembro, keynote 522 like regimen, and has a HER2 low, and I'm sure will have a residual disease TDXT type situation, then I think those would be more problematic. Here it is still
You know, the problem is a lot of those patients are really zero, the basal-like patients, and the patients of residual disease, they're not going to be
Could you
HER2
get the mic
low.
closer, please? Yeah.
And what do you say? They're not going to. I don't know. Maybe it's
No,
just
no,
me.
the mic's working. Just get it
Okay.
closer. Yeah.
It's they're not going to be HER2 low. So I think that, and then there are 2 randomized trials going on, 3 really, with either sacituzumab or datopotamab and combining with immunotherapy. So the idea has been that because HER2, even ERB2 copy number is going to be so low in the classic triple negative that they'll go with the TROP2 ADCs
Yeah.
that have shown a lot of efficacy, and then put, you got a lot of competing drugs here, trastuzumab deruxtecan, and the HR positive, HER2 low, where you see transcripts, and there's where maybe you've got a little HER2 protein, even though the IHC is low.
Okay. Dr. Davar, quick question, practical question to you. Patient, in fact, many times we're just saying HER2 negative, and he has progressed. Are you, in fact, re-biopsying them or just retesting the archival tissue for 1 plus 2 plus? What's your view on that?
If there is no recent biopsy, I would always prefer to
No,
go
would you biopsy them?
Yes,
You
definitely.
would biopsy them at
If it is
progression to look.
anywhere where it is easily biopsyable, I would definitely do a biopsy.
So they could be 3 plus as well, actually. Yeah.
3 plus, I don't know. Whether even if they are 1 plus, I'd be happy to use in a metastatic setup.
Okay, okay. This was TDXT. This is the toxicity that is very important here. As I said, we'll discuss this. There's a lot to learn. Do remember, and I think Dr. Hope, maybe this is the reason why the toxicity decreased, because the protocol was set up with a whole set of interstitial lung disease parameters, safety, and a committee was set up. But essentially, what we saw was that they have given a full guideline. This is taken from a Canadian paper, but this is based on Shana Modi's protocol, where they have written when to consider pneumonitis, how to evaluate the risk factors for ILD, and I do request everybody to read this, because this is very interesting that for grade 1, they have interrupted till they have improved with steroids. For grade 2, they have permanently discontinued TDM1. This is not something we would have expected with many drugs. Permanent discontinuation for grade 2 as well as grade 3. And in fact, for grade 3, there's immediate hospitalization as well. These are practical problems that we will face when we use these drugs. And I know, Dr. Hope, you said that your experience was slightly better. Coming to Dr. Shyam Agrawal's point, it was very interesting that they have done this exposure adjusted incidence to really look at toxicity, and when they look at that, actually the difference is not so much. But Dr. Hope, you have the biggest experience on this. So two questions that Dr. Shyam Agrawal raised was some background level of lung metastasis, which makes your lung function poorer. Is that somebody who we will be extremely cautious of? And I will come back to the risk factors. And if you notice that there is not only prior pneumonitis but some disease in that also, at least in the paper there is. And the second is renal function. This is very critical point. Dr. Hope, your view on that?
So I think that, it's good that we have this data, and we'll have more data, I think, looking at larger numbers of patients. But understanding that if you're going to treat a patient who has respiratory dysfunction, renal insufficiency, an older patient, heavily pretreated, the risk of ILD is higher. But they also have, the potential to benefit tremendously. So I start at full dose. I mean, the patients who I dose reduce for are elderly patients who have a poorer performance status and patients with significant renal dysfunction. So, really not mild, slightly elevated creatinine, but significant renal dysfunction. Those patients I start at one dose reduction.
Yeah.
But what I use is then I'm going to get a non-contrast CT scan after 2 or 3 doses of drug. And
Yeah.
I think that's really critical. You don't want to be waiting out, 12 weeks to get a CT scan. Because
And the baseline HRCT, PFT?
I don't get PFTs.
And baseline HRCT?
Well, yeah, I always get scans on everybody before I start treatment. But, yeah.
Yeah, no, but actually, we don't do HRCT as baseline. We mostly, because we are pet
Yeah.
happy
So-
country, we do more PET scans, which are 10 sections. So
We don't, the
we
PET
don't have
has
HRCTs.
that fused PET with a non-diagnostic CT is not as good at finding early ground glass opacities, and it's a really important point. That's not the right scan to be doing for these patients in general, and particularly for high-risk patients. Getting CTs is better, and nobody's ever shown that a PET is better anyway.
Yeah.
So,
Yeah.
and it's probably, and we
Anmol, you
have
want to make a
problems with
point?
insurance, so we don't get them so much.
PET CTs are not that bad.
No, it's not about bad. They're 10
Not
mm.
even 10 minutes. They are taking 2 mm cuts also. It depends on the person who is doing.
Okay.
Actually, in our center, we do a HRCT with every patient.
HRCT. So,
We are doing CCT also along with PET.
okay, so the question,
It's not a high-resolution CT, right?
Sections are around 5
Not
to
with
6
the
mm,
fused
not
scan.
to the...
No, the CT that is done along with PET is for attenuation correction, and it is not actually a high
It
resolution
is not.
CT. So ideally, if one was to look for something like an ILD, one would have to do a dedicated HRCT on a CT scan
and
machine.
Sudeep, my
Unless
point
it's
is,
really bad, and so then you've missed the very early grade 1 ILD.
Can I
That's the
just ask
problem.
one question? So, those reduced dose which Dr. Shyam Agarwal asked and Dr. Bomandabar asked, is there any evidence that the dose that is recommended is more efficacious than one dose less? How was this dose arrived at?
Because the higher doses had more toxicity. So they did it with the traditional way, and now the whole idea is you're supposed to test lower doses, but this all happened before that FDA requirement. So they actually did look at much lower doses, but the higher doses had more ILDs, so those were discontinued, not used.
I'm asking you about efficacy.
Yeah, no, that's what they were all working, right? And they went down to the dose that had acceptable ILD and stopped there.
okay, I'm now
It's
running.
the standard
Chetan,
problem we
quick.
have. you know?
We're running short of time. Chetan,
So if
quick.
somebody has a very high HER2 expression or somebody, maybe a lower dose would work. Would that?
So that's the point he's trying to make. And I think, to be fair, there are many drugs for which whom seen lowering dose does not matter, but we need to create some efficacy on
It's
that.
really a tragic that we haven't
Shobna
studied
just
that.
made a point that choosing wisely.
Yeah. But I have I have a few older patients, where I've given, for example, sacituzumab every other week, or TDXT. I have one patient getting it every 4 weeks now. She's old and she was tired, so
Yeah.
she has good response, and you just give it less frequently. So you have to individualize to the patient.
We always have to. We are very short of time. That leaves us about 10 minutes for everything else. Very interesting study. I'll start with Atul on this. Pertuzumab, high dose, heavily pre-treated. High dose Herceptin, standard dose Pertuzumab, high dose 6 milligram every week. That's not cheap either, but anyway, yes, no, maybe.
Maybe later down the course. I have never used that.
Okay.
We have used intrathecal for leptomeningeal disease.
These
but high
curves,
dose
curves
I've
are
never.
not bad. There were very small number of patients. Two did
Very
for
small,
40
yeah.
months, but
But with all
those are
the
not
newer
bad.
drugs that will, if they keep coming, I think very late down, if the patient's still doing okay, I don't know. I have no.
Anybody in the panel that's used this high dose Herceptins? Anybody in the audience 6 milligram every week? Okay, but anyway, interesting bit is we love NCC and also just like we love PET-CT, it is a part of the NCCN 2A guidelines. So I was surprised. In fact, I didn't know it existed here because for breast cancer we go to the breast cancer guideline, but the minute I went to the brain, it is sitting here. And as I said, we love NCC and as much you love PET-CT, so you will be right in choosing this at some point in some patient.
But I think if you have access to TDXD and to catnip, I think you don't know that this is going to have any efficacy at
No,
all.
but we don't have to catanib, and to be fair, my guess is not more than maybe 5 to 10% have access to TDXD. My upper limit guess is 10%. Panel, what population of India can... because you're
Less than
talking about
one.
insurance of average of 15 lakh rupees, right? One?
But you can get
What is the
pertuzumab
insurance
and high-dose
penetration
trastuzumab weekly. It's very expensive.
Pardon me?
You could get, see, we couldn't get pertuzumab late line, but you could get pertuzumab and weekly trastuzumab at a high
Yeah.
dose, and it would be a lot cheaper.
Yeah, because we have Indian generics which are very effective. So we'll get much
We
cheaper.
don't, yeah.
Okay, so HER2 climb prime analysis randomized double blind to catanib and TDM1. Dr. Gulia, your views on this in patients with brain mets and compare it to the TDXD if you can.
So TDXD is way superior
Agreed.
than togatinib plus
Yeah.
TDM.
Yeah. And significant hepatic and diarrhea toxicity, but we know how to manage diarrhea and we don't have to catanib. But you worried about the hepatic toxicity?
But that could be tackled well, and most of them responded within 22 days.
Okay, okay. Chetan, your views on this FILA trial, the pyronative with a lot of visceral metastasis here, but there was, if you notice, 57 patients, unknown time interval. So where to use this?
Maybe failed TDM1.
Okay. So this is an option if we get the drug. But again, I think it is very interesting to note that 90% had grade 3 toxicity of some sort. So difficult drugs to do. Chetan, yes. Sorry, Hope. You
I was
say?
just going to say about HER2 climb too. You know, we actually gave tucatinib in combination with Taxol, paclitaxel and I-SPY 2, and had to stop because people's,
Yeah.
you know, I had somebody whose transaminases were 1800. So liver enzyme elevation can be really a significant issue. I don't see where we're going to use HER2 climb 2.
Yeah,
And
especially.
then pyrotinib, you know, is interesting because I think if you look at navaratinib, you're going to see the same thing. I mean, you get diarrhea and other toxicities. So.
Yeah,
But
yeah,
it's very
absolutely, absolutely. And I think we're seeing that as a class effect in lung cancer as well. We're seeing this as a class effect in all of this. So quickly, phase 3 study comparing TDM1. This is the elderly patient, I think T-HER study. Okay, so brain mets, very small number, visceral mets, not too many, age, and still there was not much benefit. Dr. Dabar, your quick views on would you use this at all in your elderly population, despite of it not working?
I don't think so. If
You're still happy with docetaxel because the toxicity was clearly better, and it was not better, not worse.
docetaxel is one thing, drug where we can modify the dosing. Most of us do that.
Okay. Chetan?
There is data to say that docetaxel is equal to weekly paclitaxel in some of the situations. Why would you use docetaxel in a 65-year-old lady? I would use weekly paclitaxel, combine it with any of the HER2 targeted therapy.
Okay, Rohit, I think this is for you specifically because I think you spoke about this. So this is the Catherine updated, but do remember that these were mainly easily operable breast cancer, almost all of them, hormone receptor positive, trastuzumab in 80%, and the CNS. This was bit concerning that in fact, although obviously numbers are very small, but 7% versus 5%. So,
That was just the first episode,
yeah.
right? So overall it's the same number.
Okay, okay. Overall the same number, but still, do you think it stands today, Catherine? I mean, considering that our primary therapy has changed.
Yeah, I think till TDXT proves its benefit, and also in TDXT in this setting, right, because of ILD, it's going to be a little complicated because the amount of ILD is quite high in the metastatic setting, whether in this radical intent setting, whether it will actually show an OS benefit based on the toxicity is something. But I think definitely IDF
No,
is
I think I'm saying something different. I'm saying Catherine, while relevant in a big population, a lot of our patients are not these anymore because a lot of them are getting pertuzumab. We are using that for more LABC, not for the operable breast cancer. And the 75% were estrogen receptor positive. I'm saying, so does it really hold value in majority of our patients today?
about 20% did receive pertuzumab,
Yeah,
and by and large in India, I think till the generic comes out, I think in our practice, in my practice, 20% only receive pertuzumab.
Okay, Sudeep, you're trying to make a point?
You go to that CNS meds, you see if this is the first recurrence, then the number at risk for having CNS as a first recurrence in the TDM1 arm are higher because they are free of other sites of metastasis. So in a sense, this has to be done as a competing risk analysis because many different sites of metastasis compete to be the first
That's
site of
true.
recurrence.
Liver, lung.
So there are just more of them who can develop CNS as a first site of medicine. So this might be
Maybe
artifactual.
use a pinch of salt. Okay, very interesting. The pathological CR. Over to you on the mic, please. No, please come. Anmol, please. So I think you made a very good point. Essentially, the question you were why don't you raise that question?
So the question was, as per this meta-analysis, there is no correlation at the trial level between the PCR
But at
and
the
the
patient level, yeah.
EFS and OS. But at the same time, we are using the PCR in the drug approval trials. In fact, we have seen in the recent update of the TDM1 trial that there is an OS benefit. So how you explain this contradiction?
And in fact, this study also came out of trials in the end of the day. So how do you, Dr. Hope, do you want to take this?
For an individual patient, PCR correlates extremely well with outcome. And we saw in Keynote 522 that patients who had a PCR had dramatically better outcome than patients who didn't. So I have no question that PCR correlates with outcome. I think that the problem is that occasionally you have protected sites like brain, etc. And on a trial level, it's complicated in terms of what patients received after surgery because it's not controlled in the majority of studies until our current generation trials, that are powered for both PCR and EFS, nobody cared what you got after surgery because it wasn't an endpoint. So I think that also impacted things. What we have seen is that you can impact outcome in patients who have residual disease by giving pembrolizumab, by giving capecitabine, by giving TDM1, and maybe in the future by giving TDXT. I mean, I think these are areas where we can really make a big impact. But I do think PCR allows us a way of de-escalating because it does, in an individual patient, correlate with outcome.
Yeah. I think Anmol, the paper was relevant because it was saying that read each paper which is using pathological CR as the end marker carefully and look at the patient numbers inside rather than just reading the outcome of the paper. So TILs, I think this was very interesting. I will skip this interest of time. But quick, Chetan, you would use Monday morning, you'll ask your pathological TIL?
No, not yet.
So not yet. Okay, so we'll go quickly to voting. I heard yesterday that people are afraid of you for time. I am too.
You don't need to be afraid, sir. Our next session is a virtual talk and Dr. Gizat is online.
To be fair, there are very few conferences where time is adhered to, and thank you for doing that. Okay, quick. Will you use TDXD in HER2 low? The panel doesn't have. You can't vote. You can't. You can put your hands up. Panel. Okay, we are creating now bias and influence there. Oh, right. So the answer is clearly a yes. There are some no's and maybes. I may have thought there'll be more, but that's fine. interesting. Convinced by HER2 low at my center data. I'll just explain this before you vote. So I'm asking about, are you convinced that your pathologist is looking at HER2 low as per the criteria that are set in the clinical trials, or as per the data? So you think there's enough concordance with your pathologist, yourself, and the data for you to, are you confident and convinced of that? So at your center, would you use HER2 1 plus as a treatment for NHER2, maybe without or with doing FISH? So your conviction at that, if you can vote now. Hands up. Okay. No? Okay, good. We have a split here. All right. That is very good actually. 52% are convinced, and I think that's a good number. 32% remains somewhat confusing because of the prelude I gave, but I am still in my mind not sure how do I use this specifically because the drug is expensive and I have to be very careful. I think I keep worrying about that. Third question, confident of managing toxicity. It's a new drug with a very new kind of toxicity, and we are medical oncologists and we manage all kind of toxicity. But are you confident of TDXD toxicity right now, or should we just ask AstraZeneca, who's sitting in the audience, to say do a great please series of toxicity management lectures on TDXD? So confident of managing toxicity. Hands? Wow. Okay. So there are people confident, which is very good. That means they're ready to explore. I would have thought it's no or maybe for majority, but okay. So good. But I would still request AstraZeneca to actually do a series of lectures across India. It's a new drug. If you read the details of it and supplement, there are lots of things happening which I think we need to infer better. Now, this is a bit of a difficult question. In patients with brain metastasis at progression, forget whether you want to use chemotherapy, which chemotherapy and all, but which molecule do you believe you trust most? TDXD, tocatinib, a high dose of trastuzumab, or something else? So don't bring in the question of chemotherapy, single agent, it's just as a molecule. HER2 positive, yes. HER2 positive. Vote. For brain metastasis only and HER2 positive. Oh wow! Again, I thought there would be more tocatinib also. It's very effective. I'm asking simple question. Okay, but
I will say that the only study that looked at patients where there was a large number that had untreated progressing brain mets was
True.
Climb 1.
True.
So it's just you don't have to
yeah.
So what's the point in trusting a drug you can't give?
Yeah, fair enough. But yeah, it was very effective, and I think it was very interesting that this has been analyzed in the way it has been. Pathological CR and HER2 positive disease surrogate for long-term survival. I have not bought in your clinical trial. I changed that last minute, and because first it was saying outcome, and I said no. Actually, this is a more clinically relevant topic, which is long-term survival. Yes, no, maybe. Yeah, so I think that was kind of expected. There are some maybes, and I think that's fair too. But thank you, and this is always, as I said, always good to be here. Thank you.